We're talking a lot about end-stage liver disease, so we are backtracking a little bit. So, in any case, very good morning to everybody, or afternoon now. My principal disclosure is that I'm an unashamed liver lover. Okay, so when you think about steatotic liver disease, one paradigm that is worth keeping in mind is that it is a complex disorder which is based on gene-environment interactions. So if you have a genetic predisposition, you may get the disease. There are a few disorders like, Prader-Willi, etc., where you, just having the mutation, you will develop obesity and fatty liver disease. But in most people, the genetic predisposition per se will not allow you to develop disease. But when you have a trigger, and typically that is diet-induced obesity or excess adiposity, then you trigger one set of pathways that move the disease forward, but you also trigger another set of pathways that tend to restore homeostasis. And it's this balance between the two over time that determines whether you have progression, you have stability, or your disease spontaneously regresses. So we're not going to talk that much about the primary genetic predisposition, but really talk about the person who has already developed disease. That's the title of the talk. And we're talking about why some people may progress and some may not. Of course, the root cause of a lot of this is excess caloric consumption. As shown over here, in great majority of the world now, we have excess caloric consumption, including in Asia. And so, of course, if you vary your caloric consumption, you will vary the root cause. So, it's like having a gas burner. If you turn the gas on, flames get higher. If you turn the gas down, the flames get lower. One cause of variability. This can be further modulated by genetic markers that determine both the fat distribution and the size of the fat compartment. And these are actually data from Asia showing number of genetic markers linked to adipose tissue that are determinants of where that fat goes, whether it goes inside your visceral adipose tissue, peripherally, and how much the fat compartment can actually expand to accommodate the fat. And as you know, the visceral adipose tissue expansion is a critical part of the story because it's upstream to the liver, the heart, the arteries, and all the other organs getting sick, and drive inflammatory cytokines and create an inflammatory soup in which all these organs get sick. Another early event that changes is the gut microbiome. And this is still, I think we have just barely scratched the surface in terms of understanding how the microbiome actually affects the disease. So it can affect the disease by producing metabolites that can be absorbed, and so increases the nutritional value of the food in a sense that things that would normally be not digested are now being digested and turned into fatty acids, etc., that can be absorbed. It can release cytokines. It can release factors that can modulate the innate immune system. It can alter the gut permeability. And when it does that, you get this low level of endotoxemia, which is called metabolic endotoxemia, that turns on the innate immune system. And the degree to which all these different biological things occur can determine variability from one person to the next and can modulate the trajectory of the disease and systemic inflammation. Now, all of this converges on the visceral adipose tissue, which is really a critical upstream driver of the steatotic liver disease. It plays a role by releasing free fatty acids, changing things like adiponectin that determine your insulin sensitivity, and it's a source of inflammatory cytokines such as IL-6, leptin, etc. And it also is a source of endogenous cortisol production. So these can be modulated by PPAR gammas, can be modulated by FGF21, GLPs, many of which we use clinically for therapeutics, but really they all converge on the visceral adipose tissue. So how much you can expand the visceral adipose tissue based on your genetics, what the inflammatory cues from the microbiome are coming to the visceral adipose tissue, and how they expand, I think these are all disease modulators that are upstream of the liver disease itself. And we're learning now that there is this incredible crosstalk between the gut microbiome and the liver, the gut microbiome and the pituitary, and the gut microbiome and the adipose tissue, forming these little clocks that are all interlinked by what are called clock genes. Clock genes determine when your metabolic machinery gets turned on and when it gets turned off. And one of the first things that happens is that this biology of the clock genes gets altered. And this drives metabolically driven inflammation in different organs of the body. So all of these actually contribute to a very variable and heterogeneous systemic milieu in which the liver disease itself is developing. So we have not even gotten to the liver. We've already identified many sources of heterogeneity that contribute to the variable trajectory of disease from people to people. And then there are things that people do to themselves. And this relates to the consumption of alcohol. So if you look at the number of metabolic risk factors and the amount of alcohol consumption on the two axes, you'll see as you go from the lower left of this matrix, where you have the lowest rate of outcomes, to the top right, where you have the highest rate of both metabolic risk factors and alcohol consumption, you have the highest rate of outcomes. So again, even in people with classical non-alcoholic steatohepatitis, there are features that will tell you that this person may actually develop more disease based on varying alcohol consumption. Now let's focus on the liver. So what I'm going to do is talk about some of the key elements in the liver, from genetics, epigenetics, transcriptome, proteome, metabolome, and then cell-cell interactions. Each layer providing a hepatic layer of variability in terms of why different people progress differently. So the core elements of the disease are now well understood. Many years ago, we established this four-step pathway, starting with metabolic injury to the liver that basically causes cell stress, leading to cell death, triggering an innate inflammatory response, and continued inflammation drives a fibrogenic remodeling of the liver, culminating in cirrhosis. And essentially the key pathways in each of these steps are now pretty well worked out and actually are the basis for current pharmacological treatment of this condition. Now let's talk about some layers that modify as you go from the metabolic to cell injury to inflammation to fibrosis as features of variability. So PNPLA3 is a mutation, is a gene which is preserved from potatoes to human beings, and basically is a triglyceride lipase and is associated with more aggressive disease. And what we have shown is that when you have this mutation, you not only accumulate triglyceride, you get more oxidized fatty acids and diacylglycerols and ceramides, which activate this pathway called STAT3, which then leads to a prolonged inflammatory reaction. STAT3 is also a very powerful oncogenic pathway and actually drives cancer oncogenic signaling, linked to why PNPLA3 mutation is associated with increased hepatocellular carcinoma in the liver. And so again, those who have this tend to have more aggressive disease. Conversely, there are other genes, don't have time to go through each one, but then HSD17B13 was the first one where the mutation was protected. And we've shown in animal models that actually you can reduce fibrosis, and actually HSD17 mutation actually works by reducing senescence and senescence-related inflammatory pathways within the liver. And this has already been translated into clinical therapeutics. And a silencing HSD is now used, as shown on the right, in the phase 1 study where we actually showed improvement in all the histological features, as well as reduction in disease activity and remarkable drop in HSD with the silencing RNA to HSD. Moving on to epigenetics, this is a study from Rohit Lumba and Anna Medial using the Gilead's data showing that there is accelerated aging-related phenotypes that occurs in some of these patients. And so the more accelerated your aging pathways, the more likely it is that you will have more progressive disease, because NASH is basically a disease of accelerated aging and aging-related inflammation in the liver. Now moving on to the transcriptome, we looked at specific pathways that are linked to activity or fibrosis or both, using this formula to calculate what's called an exclusivity index. And as you can see over here, the pathways that are linked to activity and fibrosis are inflammation, apoptosis, and inflammasome activation. So the injury leading to inflammation and the degree of inflammation you get through this pathway are critical determinants of the fibrogenic response. And if you actually look at the transcriptome and do a clustering analysis, you find even though the histology looks the same, there are unique endotypes that you can see with specific clusters of genes that are turned on, which reflect metabolic, inflammatory, or fibrogenic activation, which determine the trajectory of the disease. Now, we don't have longitudinal data, we only have cross-sectional data, but very, very relevant, and longitudinal data hopefully will come soon. We have very recently also looked at subtypes of microRNAs. And we find not only there are differential microRNAs, which we showed almost 15, 16 years ago, but now we show that there are subtypes of microRNAs that are associated. So depending on the pattern of subtypes of microRNAs in the liver, you get different disease progression. And this has now been validated in multiple human and in preclinical models as well, and is moving into therapeutics. Moving on to proteomics, we showed through the NASH CRM data set that there are unique proteins that are linked to disease progression, particularly fibrosis. When we say progression, we're talking about fibrosis, progression mostly. But very interestingly, they point out to the role of complement and endothelium, and there's an emerging story of the role of the hepatic sinusoidal endothelial cell in progressive fibrosis in NASH. We have just finished the longitudinal, lipidomic, and metabolomic assessment of the evolution of the disease, and there are now clear signature for ceramides and sphingolipids. Once again, just like in PNPLA3, in those who get more progressive disease, they are the ones who get more higher levels of ceramide, changing ceramide and changing sphingolipids. So it's not only what you have at baseline. If these get worse, then you get more fibrosis. Moving on to cells, a lot of interest based on work coming from Edinburgh, particularly from Prakash Ramachandran, who published this beautiful paper showing the role of the TREM2 macrophages as drivers of fibrosis. Moving beyond that, they have the Edinburgh group has now developed therapeutics, and this is in phase 2 trials in Europe right now, which are basically modulating and converting monocytes to reframe the cellular environment so these macrophages produce factors that can modulate fibrosis. So again, the kind of macrophages you pull in and the cytokines they produce, another layer of variability that affect the outcomes. So I'll summarize now by pointing out that I've shown you at least 15 or 20 different pathways that introduce variability from one person to the other. Many of these actually induce variability within the same patient. So your transcriptome, when you have early disease, looks very different than when you have advanced disease. The metabolome, proteome, everything looks different in more advanced disease in the same patient. So if you know what's driving the disease today, you only know what's driving the disease today and not what's going to be driving the disease tomorrow. So I think we have to sort through all of those. So MASLD is a complex disorder. Several genetic, transcriptomic, proteomic, metabolomic factors have been linked to the metaboinflammatory fibrosis progression. Each step is differentially regulated in individual patients, and there's substantial crosstalk across organs, which we didn't have time to get into, that also contribute to heterogeneity in disease progression from individual to individual. Thank you for your attention.
Thank you so much, sir.